Good day. Today I am discussing acute urinary retention. Acute urinary retention is a common painful urologic emergency characterized by a sudden inability to pass urine with lower abdominal distension or pain. Most patients with urinary retention are elderly men with benign prostatic hyperplasia. The incidence and risk increase with age. There is a 20% recurrence within 6 months after an episode of urinary retention. Few data are available for women. In men with spontaneous urinary retention, the mortality rate at 1 year increases from 4.1 in patients aged 45 to 54 years to 32.8 in those aged 85 years and older. The voiding process or micturition involves the complex integration and coordination of high cortical neurologic, sympathetic, parasympathetic, and somatic, and muscular through the detrusor and sphincter smooth muscle functions. As the sensory impulse of bladder distension transmits to cortical centers, these areas of the brain smoothly coordinate voluntary urination. Continent urine storage in the bladder requires both relaxation of the detrusor muscle through beta-adrenergic stimulation and parasympathetic inhibition, and contraction of the bladder neck and internal sphincter through alpha-adrenergic stimulation. The contraction of bladder detrusor muscle by cholinergic muscarinic receptors and relaxation of both the internal sphincter of the bladder neck and the urethral sphincter through alpha-adrenergic inhibition contribute to smooth urination. Any causes that interfere with the neurologic control of the voiding process can result in voiding dysfunction. Urinary retention is the inability to void voluntarily despite a distended bladder and results from the dysfunction of the detrusor muscle and its coordination with the control of the bladder outlet. As bladder outlet obstruction progressively increases, the urine stream decreases in strength and size despite forceful and prolonged detrusor contraction. In chronic decompensation of urination, diminished detrusor muscle contractility is more pronounced with a large amount of residual urine volume compared to acute decompensation. The causes of urinary retention are categorized into several domains: obstructive, neurogenic, traumatic, infectious, operative, psychogenic, childhood, extraurinary, and pharmacologic. A detailed history of the present illness and physical examination, especially the neurologic exam, supported by imaging and urodynamic studies, reveal the cause in majority of patients. The most common presentation is an elderly male with inability to void for several hours and lower abdominal distension or pain secondary to benign prostatic hyperplasia. Specific causes of acute urinary obstruction include the following obstructive causes: benign prostatic hypertrophy, prostate cancer, phimosis, paraphimosis, meatal stenosis, urethral strangulation, cystocele, ovarian tumors, uterine tumors. Operative causes include incontinence surgery, and infectious causes include prostatitis and pelvic inflammatory disease. Causes of acute urinary retention that are not gender specific include the following obstructive causes: urethral stricture, bladder calculi, bladder neoplasm, a foreign body in the urethra or bladder, neurogenic causes such as multiple sclerosis, Parkinson's disease, Shy-Drager syndrome, brain tumors, cerebral vascular disease, cauda equina syndrome, metastatic spinal cord lesions, intervertebral disc herniation, neuropathy through diabetes or other causes, nerve injury from pelvic surgery, post-operative retention. The following traumatic causes: urethral injury, bladder injury, spinal cord injury, extraurinary causes such as perirectal or pelvic abscesses, rectal or retroperitoneal masses, fecal impaction, and abdominal aortic aneurysm. Psychogenic causes such as psychosexual stress and acute anxiety. Infectious causes such as cystitis, genital herpes simplex, herpes zoster involving the pelvic region, local abscesses, operative causes such as post-operative bleeding or clots and epidural anesthesia, and childhood causes such as posterior urethral valves, rhabdomyosarcoma of the bladder, and urethral atresia. There are also pharmacologic agents associated with urinary retention, such as alpha-adrenergic agents, amphetamines, androgens, anesthesia agents, anticholinergics, antihistamines, antiparkinsonian agents, antipsychotic agents, antispasmodics, benzodiazepines, beta-adrenergic agents, calcium channel blockers, carbamazepine, decongestants, estrogens, hydralazine, muscle relaxants, nonsteroidal anti-inflammatory drugs, opiates, progesterones, selective serotonin reuptake inhibitors, tetracyclic antidepressants, and tricyclic antidepressants. We collect past medical history to look for a history of prostatism, prostate or urinary bladder cancer, bladder calculi, indwelling urethral catheters or injury to the urethra, prostate surgery, or pelvic radiation therapy. We ask about the history of urinary urgency, frequency or hesitancy, decreased force and caliber of the stream, terminal dribbling, nocturia, and incontinence, typically due to overflow phenomenon. Gross hematuria may indicate infection, bladder calculi, or urinary tract neoplasm. A patient with the urethral stricture may have a history of Foley catheter insertion, cystoscopy, trauma, or previous radiation therapy or infection. We collect any history of new medications including common cold preparations, anticholinergics including bronchodilators, symptomimetic agents, and psychogenic and other potential agents. We also obtain a detailed neurologic history, looking for a causative lesion from high cortical function down to peripheral nerves that determine end organ function. Identify any possible spinal cord injury by determining recent activities including any remote trauma. Fever, tachycardia, tachypnea, and hypotension suggest infection or sepsis. Hypertension or tachycardia may be transient and may resolve after bladder decompression. Consider urinary retention in patients complaining of lower abdominal pain, even if they do not offer urinary complaints. On abdominal examination, palpate or percuss from the epigastric area to the lower abdomen to identify a painful mass, which is a distended bladder, in the lean patient. Examine the external genitalia to identify phimosis, paraphimosis, meatal stenosis or stricture, or evidence of urethral or penile trauma. Perform digital rectal examination either before or after relief of obstruction depending on patient comfort to evaluate the anal rectal area and prostate, assessing anal tone, perineal sensation, prostate enlargement, stool impaction, and any possibility of malignancy. A nodular or rock-hard prostate may suggest prostate cancer, which must be confirmed at a later date. Women with urinary retention should receive a pelvic examination to detect possible inflammatory lesions or pelvic or adnexal masses. Perform a neurologic examination to determine any neurogenic cause. After successful drainage of the distended bladder, a repeat physical exam of the lower abdomen is indicated to help exclude an unresolved extraurinary bladder problem such as appendicitis that needs further management. Bedside ultrasound can easily identify urinary retention. However, the need for further diagnostic tests will depend on the nature of the clinical presentation, precipitating factors, and patient comorbidities. We obtain a urine culture to identify urinary tract infection. Hematuria secondary to the physical trauma of catheter insertion that clears over time is common. A CBC should be checked for patients with suspected severe infection, massive hematuria with possible hypovolemia, or hematologic diseases. Prolonged obstruction may result in impaired renal function and electrolyte imbalance, so we need to obtain renal function studies and serum electrolytes. Formal abdominal ultrasound or CT may be indicated to identify pelvic or abdominal masses, bladder stones, or hydronephrosis, but are not routinely needed if symptoms resolve after catheter placement. Neuroimaging or spinal imaging is needed if examination identifies neurologic deficits. Cystourethography may be required eventually to evaluate the pathology in the lower urinary tract, but this is not an emergency procedure. The steps in evaluation and management of acute urinary retention are as follows. We recognize a patient with possible acute urinary retention. On the initial assessment, we obtain a complete history and physical examination to identify underlying diseases and precipitating factors. obstructive, pharmacologic, infectious, neurogenic, traumatic, childhood, or psychogenic causes. We assess the bladder volume with bedside ultrasound. On initial stabilization, we place a urethral or suprapubic catheter. For risk assessment, we assess for the risk of recurrence, need for surgical intervention, and morbidity, including age, severity of clinical presentation, causes, comorbidity, prostate size, post-void residual, and maximum urine flow rate. Need for inpatient care has to also be assessed. We admit for treatment of significant underlying medical illness or precipitating factors. We consider malignancy, spinal cord compression or injury, unresolved hematuria, or urinary tract infection with possible sepsis. The need for urologic consultation will be discussed with the urology consultant in the event of urethral strictures, meatal stenosis, urethral injury, suspected prostate cancer, acute prostatitis, or urologic postoperative complications. And for outpatient management, acute urinary retention without significant comorbidities and without evidence of complications such as bleeding, infection, or renal function impairment indicates discharge with a Foley catheter, leg bag, alpha-adrenergic receptor blocker such as alfuzosin or prazosin or tamsulosin, alfuzosin at 10 milligrams daily and tamsulosin at 0.4 milligrams daily, and follow up with urology in 3 to 7 days. If the patient recently underwent urologic surgery such as radical prostatectomy or complex urethral reconstruction, we consider the urologist before any attempts at catheter placement. So for the urethral catheterization technique, most catheters are made of latex, but silicone catheters are available for patients with latex allergy. The retrograde injection of 10 to 15 ml of water-soluble anesthetic lubricant such as 2% lidocaine jelly 5 to 10 minutes before inserting the catheter can alleviate patient discomfort. We retract the foreskin when inserting the catheter and remember to reduce the foreskin once the catheter is in place. The catheter is in place when urine is freely draining. Do not inflate the retention balloon until urine begins to flow through the catheter into the clear extension tube. The urethra can be injured from inflation of the retention balloon within the urethra. If the catheter balloon is inflated in the prostatic urethra and not the bladder, urine may or may not drain freely, and balloon inflation causes extreme pain. Forceful attempts at catheter removal with the balloon still inflated can cause edema and tears to the urethra. If attempts at passage of a straight 14 to 18 French Foley catheter fail, use a firm angulated coude catheter positioned so the tip points anteriorly. The curved tip adjusts to the course of the prostatic urethra. A modification of the standard catheterization technique was reported in a small convenience sample using ultrasound guidance while applying transrectal pressure to help smooth out the course of the prostatic urethra and simultaneously gently advancing the catheter. Applying this technique requires two healthcare providers, one using ultrasound and applying rectal pressure and another advancing the catheter. During insertion, a false lumen can be created or the catheter may kink in the urethra, especially in patients with underlying urethral strictures or prostate enlargement. We consult urology for the management. If catheterization produces gross blood, we deflate the balloon, remove the catheter, and do not attempt reinsertion because a false passage through the penile soft tissue instead of the urethra may have been produced. Suprapubic catheterization can be performed in patients after failure of several attempts of urethral catheterization as long as there is no obvious pelvic trauma or abnormal anatomy in the lower abdomen. This may be the only option to decompress an extremely painful distended bladder when urethral catheterization is not possible. Ultrasound-guided suprapubic catheterization has a low complication rate. Prepare the suprapubic area with betadine and local anesthesia. Visualize the distended bladder with ultrasound. While monitoring with ultrasound, advance a 22-gauge spinal needle with 10 ml syringe posteriorly and caudally at a 30-degree angle from the true vertical and 60 degrees from the horizontal plane of the abdomen, 3 to 4 centimeters above the pubic symphysis in the midline. We advance the needle while withdrawing on the syringe. Ultrasound visualization of the needle in the bladder and urine return indicates correct placement. Use the depth and precision of this attempt to direct the placement of the obturator. Make a small skin incision in the midline at the point of prior needle removal. The cystostomy catheter and obturator assembly are then placed in similar manner as the spinal needle, again after aspirating for urine. After inflating the retention balloon, withdraw the obturator and leave the catheter in the bladder. Secure the catheter with a suture. If a guide wire is used for catheter insertion, remove the pull-apart sheath after successful bladder placement. Patients with long-standing obstruction are at risk for post-obstructive diuresis and post-obstructive renal failure. We monitor for 4 hours minimum for significant hourly urinary output, which is more than 200 ml per hour for input after initial return. If this degree of output continues, we admit the patient with volume replacement adjusted hourly according to urine output. Patients with significant elevations of BUN or creatinine should be admitted. Patients should be reassessed after Foley insertion for resolution of symptoms. Routine use of antibiotics for the prevention of bacteriuria or for the treatment of asymptomatic bacteriuria is not suggested. Antibiotics are reserved for symptomatic urinary tract infection. Pharmacologic therapy with an alpha-adrenergic receptor blocker, which exerts its effects on the bladder, neck, and prostate, may relax bladder smooth muscle, reducing outlet resistance to urinary flow. Alpha-adrenergic blockers such as alfuzosin 10 mg daily or tamsulosin 0.4 mg daily increase the success of spontaneous voiding after the catheter is removed. Warn patients, especially the elderly, about possible post-ural hypotension. Alpha-adrenergic blockers may also shorten the interval of time before a successful voiding trial and prevent recurrent episodes. Majority of patients with urinary retention are discharged home with a catheter connected to a leg bag and wait for further surgical intervention after the urology clinic visit. Patients should be educated in Foley catheter care and bag drainage and given a list of alarm symptoms such as fever, return of symptoms, repeated vomiting, abdominal pain, catheter blockage, or penile pain. Penile pain suggests migration of the balloon into the proximal urethra. Feelings of urgency or bladder spasm can be treated with oxybutynin 2.5 mg per orem 2 to 3 times a day. Oxybutynin has anticholinergic properties and can cause the same adverse effects as any anticholinergic agent. There is no satisfactory treatment for urinary leakage around the catheter. Placement of a larger catheter is not typically effective. Alpha-adrenergic blockers can be prescribed as needed. Recommend urology follow-up within 3 to 7 days. A longer period of Foley drainage is encouraged in patients with retention volumes greater than 1.3 liters to improve chances of successful voiding. The serum prostate-specific antigen assay and long-term use of a FALV-alpha reductase inhibitor could be evaluated at urology follow-up. For precipitated urinary retention, remove the catheter in the emergency room and allow a voiding trial. Discontinue any offending medications. Patients with clot retention, hematuria, and coagulopathy, sepsis, possible neurologic causes of urinary retention, or other significant comorbidities should be admitted. Urinary retention in women is uncommon. The obstructive causes of urinary retention in women are usually related to gynecologic problems, but neurogenic causes can develop in both men and women. The management of urinary retention in females involves catheterization and attending to any treatable cause. The ideal selection of catheterization method including in and out catheterization, short-term indwelling urethral catheter followed by a trial of voiding, or clean intermittent self-catheterization depends on the clinical assessment of precipitating factors and underlying conditions. Alpha-adrenergic blockers do not appear to be helpful in women with urinary retention. If there is no apparent cause, refer to a gynecologic urologist for urodynamic studies. Gross hematuria can lead to clot formation, resulting in pain and hypertension and tachycardia from acute bladder distension. Management of gross hematuria is the placement of a 20 to 24 French triple lumen catheter with one port for urine drainage, one port for balloon inflation, and one port for bladder irrigation, and irrigation with saline until clear to evacuate clots. Patients with clot retention may require admission because clot retention may reoccur and may require cystoscopic clot removal. Patients with gross hematuria from coagulopathy, such as with warfarin intake, should have clotting parameters corrected as appropriate and be admitted. So just to recap, acute urinary retention is painful, it's common, and it's a urologic emergency characterized by a sudden inability to pass urine, with lower abdominal distension or pain. Most patients with urinary retention are elderly men with benign prostatic hyperplasia. Micturition involves the integration of high cortical neurologic and muscular functions. So, beta adrenergic stimulation and parasympathetic inhibition relaxes the detrusor muscle, and contraction of the bladder, neck, and internal sphincter is mediated through alpha adrenergic stimulation. So, this is continent urine storage, and the reverse happens with urination, in which cholinergic muscarinic receptors contract the bladder detrusor muscle, and relaxation of the internal sphincter of the bladder, neck, and urethral sphincter occur through alpha adrenergic inhibition. So, causes of acute urinary retention can be divided into obstructive causes, neurogenic causes, traumatic causes, extraurinary causes, psychogenic causes, infectious causes, operative causes, childhood causes, and pharmacologic agents. Among pharmacologic agents, alpha adrenergic agents, beta adrenergic agents, calcium channel blockers, carbamazepine, estrogens, hydralazine, muscle relaxants, NSAIDs, opiates, progesterones, SSRIs, and other antidepressants such as tetracyclic and tricyclic antidepressants are usually associated with urinary retention, as are anesthesia agents. Bedside ultrasound can usually identify urinary retention very easily. We also obtain a urine culture, a CBC, to check if the patients have severe infection, massive hematuria with possible hypovolemia, or any hematologic diseases. If prolonged obstruction is suspected, we may also need to check for renal function tests and electrolyte imbalances. And abdominal ultrasound or CT may be indicated to identify pelvic or abdominal masses, bladder stones, or hydronephrosis. Treatment usually includes assessing the patient, stabilizing them. So usually we insert a catheter, but for patients with long-standing obstruction, they may have post-obstructive diuresis and post-obstructive renal failure. So we have to monitor for 4 hours minimum for significant hourly urinary output, which should be greater than 200 ml per hour over input. And other considerations in urinary retention include females with urinary retention, because it's not common there and it's usually due to a gynecologic cause, gross hematuria and clot retention, for which irrigation may be performed, or cystoscopy, and postoperative urinary retention, in which the surgeon has to be consulted. Our reference is Tintinalli's Emergency Medicine. Thank you.